Yes, this is a 15-year-old female presenting with decrease in vision in both eyes. Vision in right eye was around 6 by 60 and left eye was counting finger 2 meters with near mature cataract in the left eye and what seemed to be a posterior lenticonus in both eyes. That is what I was suspecting because the posterior capsule was so deep on anterior segment examination on the slit lamp. That is what I thought. I thought I was dealing with posterior lenticonus, but there was a big surprise waiting for me on the table. Let us see how this case goes. I am doing the rexus since the capsule, anterior capsule is elastic. I prefer to do it in Utrata. That went well. The whole rexus part went well. After gentle hydro, I tried to rotate. It was not rotating. I did not force. I did not do it twice. So I decided to go in my phaco probe. Cataract was very soft, so I was in cortex mode, not in my phaco mode. So the aspiration itself was very simple. Once I was doing phaco aspiration, once I was halfway through, then I realized what this case was. There was, as you can see, now you can see a big posterior capsular tear staring at me. Now this was a surprising thing. I didn't expect this at all on my slit lamp examination. As you can see now, it's quite clear. There is a horizontal tear between 3 o'clock and 9 o'clock position, which was pre-existing, which was seeming like a posterior lenticonus on my slit lamp examination. Before coming out, once I realized there was a big tear, I wanted to reform the AC and reassess the situation. Since there was very minimal cortex left, I decided to go with bimanual irrigation aspiration and take out whatever little cortex is there. The trick here is not to let the cortex fall into the posterior chamber, into the vitreous. Luckily for me, the anterior hyaloid face right now was intact. There was no vitreous prolapse, so I was able to do this step quite comfortably. So once that was done, my next step was to assess what is the amount of vitreous prolapse I had in the AC. So I have put the tricot and washed away the excess of tricot, and I am going with my kata. This I am going in with the 2000 cut rate, aspiration mode. So I decided to take out as much vitreous as possible, anterior hyaloid face as possible, since this is quite a young patient, and clear as much vitreous as possible in the AC. As you can see, I am taking out as much anterior hyaloid face and the vitreous which has not prolapsed that much into the AC as possible. The white thing what is floating around in the posterior chamber is the tricot which has gone in. So I could remove how much ever possible. That's okay. If it is remaining in the posterior chamber also, it will get absorbed in a week or two. That is not a problem. So I was able to do the complete vitrectomy part and reassess the situation once that is done. Once the vitrectomy is done, I inflated the bag with sodium hyaluronate, which is a high molecular weight visco. This helped me in assessing the amount of tear, and once that is done, I decided to go in with single piece IOL. This is single piece hydrophobic IOL. As you can see, the tear is in at 3 o'clock and 9 o'clock position. I decided to put in the IOL at 6 o'clock and 12 o'clock position in the bag, and what my plan was now is putting the single piece IOL in the bag and doing a optic capture, because I had around 5 millimeters intact rexus. So the lens is nicely sitting in the bag, quite stable. Once that is done, I removed excess of visco and sodium hyaluronate which was there in the AC, and just to make sure there are no vitreous strands, I did a tricot wash in the AC. As you can see, there is no vitreous strands. So once this is done, I was able to close the case. Thank you.